Jim, over to you.
Yeah, thanks, Nikki. Hi, everybody. You probably noticed I couldn't help myself. I had to spell it the European way, the UK English way, catastrophizing. So there's a mixture of S's and Z's in the paper. Just couldn't help myself. But yeah, so sorry, Andrea. It's great to have you with us, one of the authors. And yeah, we're just going to have a look at this. That's the QR link to it if you want to have the paper yourselves to read afterwards. And as you can see, there was a large authorship to this. So what we'll do is we'll kind of skim over the question, how it was done, what it was, and then maybe spend more time in the findings and the discussion part afterwards, if that's okay. So if we go down here, so who wrote the paper? Well, there was a large group, as you can see, and they are from all over the world. I had to look, but actually the majority are from
Sorry, Diarmuid, I've just had a comment to see if you can talk any louder, and you are a little bit quiet on my side as well.
Hang on, sorry. This is going to get really loud because it does this. 2 seconds. Is that better? Sorry, I don't know why. I think Zoom thinks I shout at it, so it turns down the volume on me, and then I have to turn it up. There we go. Don't worry about the writing. I'd written down here of just basically all the different universities, but the majority are from North America, predominantly Stanford University and Canada, but also from Ghent University. And I think there were a few people like Andrea who were not affiliated, and I guess I was looking at trying to spot who are the people with lived experience. And I suppose overall that was perhaps one of the things that I guess, particularly for this group, that we're interested in is who's contributing, who might be people with lived experience, because that's obviously really important. And there is a part in the towards the end of the paper where they say people's involvement, and it does say patient collaborators and a subset of scientific collaborators participated in the design of the surveys. I think for me, maybe one disappointment was that perhaps wasn't more on the kind of the background. And Andrea, hopefully we can hear from you a bit later on that involvement, because I think that's really valuable and interesting to know that part of the story. So yeah, we'll have time to come back to that and just you can give us more detail on that. But in the paper itself, and maybe this is often the case in writing papers and the formats that journals want, and they sometimes don't place value on that information, but I think that's probably, to me, more valuable to know that side of things. So that was just something to say. How is the study funded? Again, maybe this is the critical side for me, but these are the types of things I now look at is where's the money coming from, who's writing it, and why, because that sometimes speaks to motives, but this was predominantly funded by grants from the National Institutes of Health, which is, I guess, the US version of, in the UK, we have the NIH, the National Institute for Health Research. So it's a government-funded body that's responsible for distributing funding to support research into health, alongside a grant from the Canadian Institute of Health Research, which I guess is like a sister organization to the two I've just mentioned, but based in Canada. So that's where the funding comes. So all great there. And I thought we could maybe think about what is catastrophizing. So the paper as all papers are laid out, they have a background section, which kind of gives a bit of an overview of this term and where it's come from. And please, Nikki, Chris, and Andrea, feel free to add to this. But what I was taking from the paper is that the term itself first arose in 1962 in kind of with an emphasis on kind of looking at emotional dysfunction, and they provide a quote which was, "It is exaggerating adversities into something far worse than they actually are, seeing things at their worst when they are sometimes relatively minor, and greatly exaggerating the frequency and or danger of something that you dislike." So that was how it was defined then, and I think that's, I'm sure, going to be open to all sorts of thoughts from all of us as to perhaps the inherent judgments in the way that it is defined right from the get-go. It was adopted then almost over 20 years later to look specifically more at anxiety and depression. And then they described it as a maladaptive cognitive style. And I think maladaptive is an interesting word. We often see it used, I think, as a fancy way of saying something that we don't understand why it might be helpful. I think it's how I might interpret it, but it's quite a negative way of saying it. It's saying we've evolved this thing and it's not helpful. It's a bad adaptation, I guess, is almost a literal translation of it. A bad adaptation to how we think is what it's being defined as. And then when did it start to be used more in pain? Well, in 1987, it was introduced into pain with the coping skills questionnaire, and in particular, a subscale or a part of that questionnaire that they decided this is something interesting. We think it's related to pain. Since then, it was then kind of updated in 1995 when it was turned into what's used quite widely now, the pain catastrophizing scale, or the PCS. And this is what really spurred wider measurement and use in clinical and research settings. So it's not in the paper, but I thought it might be helpful to think, well, what is this scale, the PCS? Might it be useful to see what that is? So this is it here. And sorry, it's a small picture, but it basically consists of 13 questions and for each, or statements, and for each statement, you have to rate them from 0, which is not at all, as in it doesn't apply to you, up to 4, which is it applies to me all of the time. So the statements include, I'll read them out. I worry about all the time about whether pain will end. I feel I can't go on. It's terrible and I think it's never going to get any better. It's awful and I feel it overwhelms me. I feel I can't stand it anymore. I become afraid that the pain will get worse. I keep thinking of other painful events. I anxiously want the pain to go away. I can't seem to keep it out of my mind. I keep thinking about how much it hurts. I keep thinking about how badly I want the pain to stop. There's nothing I can do to reduce the intensity of the pain, and I wonder whether something serious may happen. So these are the statements, and then people are asked to rank them from 0 to 4. And it kind of is looking at 3 different domains or areas of what could be considered coming under this umbrella of catastrophizing. So one is rumination, one is magnification, and one is helplessness. So I'm looking to Chris and any of the psychologists in the room. Do you want to give a elevator one sentence on what's rumination? How would you define it?
Yeah, I guess rumination, I would define it as overthinking. So it's like you're kind of you're mulling over. They refer to, like, if a cow ruminates on the grass, it's just like passing it round and round and round. It's not actually getting digested, and a similar thing with the with your thoughts.
Lovely. I love that image. Cow chewing is called. That will help me for now. So these things that we don't tend not to let go of and keep churning over. And then magnification, I guess, is more easy to understand what that one is, and then helplessness. So different statements relate to those, and basically the score is from 0 to 52. And in terms of how it's measured, people who score higher than 30 are considered to have a greater degree of catastrophe. So that's kind of the score that has kind of almost, if you like, spurned this whole use of this term in pain specifically. By the way, please feel free to unmute and ask questions if you've got them. Try and keep this as light as possible. What was interesting again in the background, so they give a history of the term, where it's come from, and then they do, and I did wonder whether this is part of the authorship team, because especially the Canadian authors come from critical kind of disciplines where they question kind of where things have come from, the benefits, and perhaps the opposite, the kind of ways that things might be unhelpful. So I thought that was really nice to see them speaking to perhaps, actually there are broader contextual factors with pain. So catastrophizing may not be looking at that, and kind of speaking to issues of structural issues like poverty, and how regardless of someone's score or how much they catastrophize or not, whatever that means, that actually there are things that are outside of our gift to necessarily change or control, and it's important to acknowledge them. It's important to validate a person's pain experience, and that actually maybe one of the values in considering this concept of catastrophization might be as a means to explore with people possibilities for improving their sense of control, even within the context of all these difficult external factors which they may have less control over. So I thought it was a really nice way of framing to think about how might this be relevant, and that was in the introduction. So,
sorry, can I just say one thing? In that, I just really liked that the paper talked about that long absent from the patient-reported measurement is the quantification of stresses experienced from seeking healthcare. And I thought that was, I liked seeing that they noted that, because it's something that we don't see very often in the literature. It seems to me that how stressful it can be negotiating the system.
It's so, thanks. And that kind of resonated, also for me with the work we're doing in liminality, exploring that, because that was a theme that's coming out, is people, the stress of navigating these systems or not being able to navigate them because of all the obstacles and challenges. So recognizing and acknowledging that is important. Andrea?
Yes, I just to speak to that point, because of exactly what you said, we are in the process of developing a healthcare stress survey, a validated instrument that is a way for patients to explore or explain the stresses that they're experiencing in navigating healthcare, a metric that has never been important or measured before, but that is something we are recruiting for that trial right now. So I just wanted you to know it's really important to us to capture that as well, and that's in process.
Well, that's brilliant. Thank you so much.
Yeah, wonderful. We'll look to that one with eagerness. Thank you. So, okay, so how is catastrophizing defined then? We've kind of given a bit of a background and history, but what actually is it? How is it defined? So in the paper, I think they settled on there's a negative cognitive and emotional response to pain was where it settled. But kind of looking through it a bit more, there was a discussion in the background around, well, is this a helpful term, or might there be more helpful terms that we could use, a renaming of it as it were. So one that they introduced was pain-related worrying, which I thought was interesting, and then another which was a concerns about pain scale, rather than calling it catastrophizing scale. So, and we'll come on to this a bit more, because there's as part of the survey there was a offering of lots of different ways of perhaps naming this to see if people had a preference. So, but just to give a elevator pitch as to what the definition means as they used it, this is what they said about negative cognitive and emotional response to pain. So what was the purpose of this research study? Well, they state two, which one is to understand the perspectives of stakeholder groups with regard to the term itself. So, people's thoughts and opinions on the term pain catastrophizing. And the second purpose was to understand whether improved and patient-centered terminology might be indicated. So there were two purposes really for this paper, as stated in the paper. And then they identified three aims related to that. So the first was to understand the prevalence of patient exposure to the term pain catastrophizing. And they did in the paper say that they're using the term patient because they did ask people what their preferred term was, and that people with lived experience with Andrea said that actually let's use the term patient in this, and that was, so they kind of spoke to that, which again was nice to see in the paper, that they're considering even the use of the terms that they're using to describe people who are living with pain, who this is relevant to. They also wanted, so they first wanted to understand how many people who live with pain have actually encountered this term, are aware of it in that sense. Secondly, they wanted to understand, for those who haven't come across it before, what are their experiences and perspectives on it. And thirdly, whether an alternate term might be needed. Sorry, this is a very busy slide, but I'll just, so the methods that were used, it was an observational cross-sectional study with a broad distribution of invitations, collection of data and analysis of that. Now, basically, in plain English, what they did is they advertised on social media within their networks, and it was quite a distributed network, but as we noticed from the authors, it was primarily North America, Australia, Belgium, and then I guess the networking spread out from there. So yeah, that will have an effect on who, I guess, will see the adverts and who will respond and answer the questions. But that's one thing. So there were 12 patient stakeholder collaborators based in 4 countries that shared this. There were 32 scientific stakeholder collaborators based in 9 countries who shared this. And then there were 2 international organizations, GAPA, the Global Alliance of Partners for Pain Advocacy, which I'm a member of that, as well as the World Patients Alliance. So there was a lot of really trying to get this out to all relevant stakeholders so that they could share it in their communities to try and increase the uptake and the completion of the forms, of the survey, sorry. Because it was a survey, it was deemed exempt from Stanford University's Institutional Review Board. I'm taking that to mean that they didn't need ethics. They don't use the term ethics, but that's really what they're saying. For lots of research, normally there is a statement of ethics. In this case, it was deemed not necessary to have ethics because of the way they were promoting it through advertising, and people could choose to respond to that or not themselves. And the survey was, there was 2 parts to this, and this paper is really reporting on the patient and caregiver arm, but they're also interested in clinician and researchers' opinions on this, and that was a separate one. So the advert would take people to a website, and depending on how you respond to the initial questions, it works out whether you are a person living with pain or their caregiver, in which case you would be directed down one route, or if you're a clinician or a researcher, you would be directed down a different route. Okay. And I thought it would be useful to put the actual language in the advert here so we can see how they framed it. What they say is this is a patient-centered project being led by a group of committed pain researchers, patients, patient advocates, and healthcare professionals. We aim to understand the perspective of patients, researchers, and healthcare professionals with regard to the term pain catastrophizing. We will be collecting and collating the information we receive from your responses to help us to understand whether it's time for a change in the use of this term, and possibly to create new terminology that is, and I've missed the last part of it, so that's, why is that not there? It might be the way it's cut, but I think it was something along more patient-friendly or more user-friendly, I think was the last part. Sorry, I don't have it now in front of me.
Yeah, the last line. Right, it just says to possibly create new terminology that is compassionate, patient-centered, and more considerate for use in the medical community.
Lovely, thank you. So I think it's useful to know that, because I suppose so one thing that piqued my interest is how we frame, how we advertise things might betray our thoughts on it in the first place. And so people will see that through how it was advertised initially. It's always a balance between that and giving enough information for people to find this interesting, to want to follow the link to go to the website to then complete the initial part of the survey. So who is excluded from this? People, so it's for adults, so no one under 18 would be included. People who weren't having current, ongoing, or past chronic pain were excluded. Although caregivers were used, so somebody might not be able to complete it themselves, but if they had a caregiver, they could complete it on their behalf, and that was okay. So there were some people completing it without, but the majority, I think it was 95% of people who completed it were living with pain. So when they chose, when they gave that information, which identified that they were going to be completing the patient or caregiver one, this is what they then saw. Our goal, we aim to understand the perspective of patients with long-term pain with regard to the term pain catastrophizing. We plan to research and develop a new term that is patient-centered and more considerate for use in the medical community. We appreciate your participation and opinions, and thank you for your thoughtful contributions. All answers are anonymous and will be kept confidential. For any free text responses, please do not include any identifying information so we can keep your responses anonymous. So that was what, that was the introduction to the survey for people to complete. And then I thought, again, apologies, I just thought, well, in the supplemental data, you can find the survey itself, and it's got a range of questions. The first 5 questions are more demographic. So, you know, do you have pain? Yes, no. And if they answered no, then that would automatically exclude them from the survey because they're not living with pain. What's your age, your gender, which country do you reside, how long have you had the pain? They were their demographic pieces. And then the remaining questions were more around the term itself and some free text ones. So have you heard of the term pain catastrophizing? if they say yes, then it will ask them when did you first hear the term? Where, sorry, did you first hear the term? They're given options of physician, non-physician, online or in print material, in a clinical survey or somewhere else, which they could complete if it was somewhere else for them. Has a healthcare provider ever described you as being a pain catastrophizing? Or said that you were catastrophizing your pain, or used the term to discuss your pain care? So again, these questions are trying to understand how people have been introduced to the term, where it's being used, and particularly if healthcare professionals have used it when they are discussing their pain and their care. And so it takes you into the next one, where they have to answer a range of questions based on a 1 to 7 scale, where 1 is I strongly disagree with this statement, to 7, which is I strongly agree. And the statements where I felt blamed for my pain. So where people did hear this term, they would be asked to comment on I felt blamed for my pain, whether they strongly disagree or agree with that. I felt judged. I felt my pain was dismissed as being purely psychological or in my head. I felt it was taken less seriously. I felt the information or this term was used against me. And I felt this information was used to prevent my access to pain treatment. And the final one, so then they were asked some kind of more open questions, but before that they were given a definition of pain catastrophizing, and then told us asked what first comes to mind when you hear the term catastrophizing. So it was a free text response. People could put in whatever they wanted there. And then the next part was offering some possibilities for a new term, which included pain-specific distress, negative pain mindset, negative pain appraisal, pain-related worry, pain-related anxiety, pain-related fear, pain-related distress, or pain vigilance. And people were asked to kind of rate those on how much they disapprove or approve of them, or whether they're neutral, which is in the middle. Okay, so they're given options for lots of them. And then finally, please feel free to add any further comments. And the final question, if there was anything else you would like to tell us on this topic. So there were 3 open text questions, because that's important, because that's was analysed using thematic analysis, which we're on. So is that okay? Any questions on that? I'm just conscious it's a lot of information there. Yeah, shall we think about the results? So they kind of divided the results up into the more quantitative, the hard data part, and then the qualitative, so those open-ended questions and analysing those. So if you like, the facts were 3,521 people kind of followed the link initially, and of those 2,911, so 82, nearly 83% completed the survey. So that's a huge number of respondents. And I guess you can tell from all the work that went into advertising and promoting it and using the networks that they got such large numbers completing it. Amazing. Now, you don't normally get that big a data set, so kudos for doing that. Of those, 95% continue to have pain. 68% of people have had pain for more than 10 years. So a large percentage of this group were living with pain for a long time in completing this survey. The majority were female, 82%, 15% were male, 1% were non-binary, 1% preferred not to say, and 1 respondent was other. There were 47 countries represented in this, which was, again, a lot. But when you look at it, 77% were from the USA. So the majority, I guess. And these things are important when we start to think about generalizability and how relevant this might be in other situations and for other populations. But nonetheless, Canada then was the next largest number, 7.6% response. Then we had Australia and the UK, 3 and 4%, the Netherlands. And then everywhere else was 5.8%. And there was lots of countries in the everywhere else. But I guess smaller numbers replying from those countries. The survey itself was in English and Spanish, so 2 languages. And that was interesting to me because the PCS, the scale itself, has been translated into 20 languages. So it's interesting that the survey was in 2 languages. So that's just something to pick up. Of the respondents, 44.5% had heard of the term. 12% had experience of healthcare professionals describing them as a catastrophizer. And for those, they reported high levels of feeling blamed, judged, and dismissed when it was used to describe them and their pain. And then the open-ended questions, and this, I guess, is the meaty part, I think, in some ways, and Niki's picked out some quotes for these, but they basically, they used what's called thematic analysis, which is a method that's, I guess, promoted strongly by Brown and Clark, and it can be used. So often the way we analyze data depends on the kind of position we take as researchers and our belief systems, whether we believe there's what's sometimes called positivist approaches, where we believe there is one truth and we just need to work out how to find that truth. And that's often in big pharma trials, that's the type of approach that's used. So it's called positivist. Whereas an alternative to that might be more interpretivist, which acknowledges that reality, there isn't one true reality, and reality is an interplay between humans and structures and systems within which they are placed, and the power dynamics associated with those. So often qualitative approaches are there, and thematic analysis is kind of theoretically flexible, so it can be used across a range of different underpinning philosophical stances. And I'm just sharing that because I think it was interesting, because they used thematic analysis, although the questions were quite directed towards understanding specifics about this term catastrophizing. And when I've seen thematic analysis used, it's mostly used almost where there's really broad questions, and so there can be a lot of variation where people take their comments and then you use that to analyze and try and see if there are any patterns and themes. So I'm sharing that because I think some of these 5 themes, I guess, make sense when we think of what the questionnaire was and how it was directing people to ask, to think about these things. Because the 5 themes they constructed, I'm going to say, they use the word emerge, but again, that suggests that they're already there. Actually, we construct themes because we as researchers bring in our thoughts and our ideas to the data that we're looking at, and then we try and construct our themes. So the first one was, what does the term pain catastrophizing mean to patients? I'll just read them all out, shall I, Niki? And then you can give some examples of the quotes. The second was, there were consequences of the term on patient experiences. The third was that there was association of the term with negative gender stereotypes. The fourth was that there were suggestions for a new term. And the fifth was that there was opposition to the concept of pain catastrophizing and creation of a new term. So, Niki, do you want to share some, because you've been kind of looking at the quotes and that in the paper?
Yeah. I mean, I'd suggest if anybody's interested, it's an open source paper, so you can go and have a look at them yourself. But I've picked a few out. So this is in the first theme about what does the term pain catastrophizing mean to patients. And one of the quotes is, pain catastrophizing brings to mind someone who exaggerates how much pain they're in order to gain sympathy or more pain meds. Even though that's not really the definition of it, I think a lot of people relate the word catastrophizing to exaggeration. You need to separate these misperceptions with different terms. Then some people indicated that the term was reasonable or useful. Somebody said, I'm okay with the term since it reminds me of my role in the pain process and my attitude towards pain is critical. In the next detail, I've got another one that I've got a little cross by, so it must be really important. On one level, I understand that it may be an accurate psychological term to describe catastrophic thinking patterns associated with experiences of pain. I found it useful to recognize that some of these thought patterns aren't helpful for me in managing my pain levels and to develop alternate ways of thinking. On an emotional level, I find it a bit demeaning and blaming. It carries the implication that my pain is imaginary or that I'm exaggerating it. I resonated to that one myself quite strongly, so that's why I've got a cross with it.
I actually thought you might have written that one.
I'm sure I did actually fill in this questionnaire. The next one was consequences of the term on patient experience, and I've got One person said that they found, I find it very victim blamey to use pain catastrophizing, and that it is often weaponized against disabled people, especially those who don't have a clear medical explanation for their pain. Somebody else said, the term implies that the patient makes their pain worse by letting it control their thoughts or actions. It implies that the patient could lessen their pain if they'd only try hard enough not to think about it. I felt demeaned, like the pain was all inside my head, especially at the time when no one could figure out what was wrong with me. So when you have severe chronic pain, the kind that disables you, it's all encompassing. It affects everything you do, your relationships, etc. If certain tasks or actions make it worse, of course you're going to avoid doing those things, especially if your pain isn't well controlled. The association of the term with negative gender stereotypes. Somebody said, I despise this term from both my bioethics and CRPS, chronic regional pain syndrome, patient perspectives. It continues a long history of healthcare apparently infantilizing or downplaying women's health issues, particularly chronic pain conditions. I associate the term pain catastrophizing with the ways in which hysteria was historically used to describe women's medical conditions. As a patient with neuropathic chronic pain, joint pain, etc., I don't catastrophize, I plan. I highlighted a section in somebody else's comment about this. It said, it seemed like I was being told I was faking it or not tough enough, weak, and attention seeking. In a broader perspective, one respondent applies a gender lens to describe this experience, noting how women have been traditionally seen being viewed as more emotional and less rational, and that it could be very easy to blame the patient for the pain. Going on to the suggestions for a new term, a lot of people seem to suggest that it was just be called pain, which was interesting. Have we got any others? But yeah, I mean, we can sort of look here. It says it's somebody. The cross I've got on it, the one cross I've got on it is, it needs to be emphasized that this vigilance is normal human reaction, in capitals. I like vigilance as long as it isn't hypervigilance as well. That is descriptive. That's another term that is becoming pejorative. Over to you, Clement.
Thank you, Niki. It's always much more powerful, isn't it, hearing the voices of people themselves. So thank you. I think some things that stuck out for me on this was when they were asked. So for the first theme, which is a hard word to say when you have an Irish accent, first team was around this term, and of the respondents, 1,839 people replied. 68% of patients did not spontaneously report negative experiences or responses. I thought that was interesting, in given how the questions were framed, and that actually over 2/3 did not spontaneously report negative experiences or responses, but just an interesting thing to me in the data. That struck out for me. What else struck out for me? Only 154 respondents questioned the reason for the current term in their responses. Again, that felt quite low given the nature of the survey and how it was set up and the questions that were asked of people. So that was just curious to me. A small number of respondents, 324 out of that nearly 3,000, suggested that there needs to be more empathic and ethical responses to patients who suffer with chronic pain. But that kind of piqued my interest because it didn't really kind of make sense in terms of perhaps the bigger picture of the paper and what was being asked. So,
sorry, Jimmy,
yeah,
was there wasn't any indication of where people were accessing their care in this? Because it seems to me that a lot of people have negative experiences with catastrophizing when they're sort of in pain management, when they're accessing a sort of, maybe should we call it a higher level of care, certainly in this country. If they're just seeing their GP, they probably wouldn't have heard the term.
Well, yeah, and again, maybe thinking about the demographics of the population you filtered in, and 78% maybe from the USA, and then 7 or 8% from Canada, and then, you know, gradually less and less from other countries. I don't know whether that makes a difference or not. I guess it's worth, yeah, considering. But yeah, no, the survey itself, as you saw with the question, doesn't really, I mean, there was a lot of information already gathered, so it's kind of that, where do you stop collecting information on people? But yeah,
they do ask, don't they, where they heard the term from. I wonder if that would sort of highlight it a bit more, because I know a lot of people who have positive responses to pain catastrophizing are people who found it themselves, or you know, in my sort of thing. So again, well, I won't bring out the Philip Larkin quotes just yet, but
yeah, no, maybe later after the watershed. So as with all papers, there's always a section on what are the, you know, the pros and cons of this. So what are the kind of the things to highlight as being good, and what are the things that could be better, I guess. So the kind of strengths and weaknesses, or strengths and limitations, I think is a word that's used now. The vast majority of surveys were from female residents of Western countries. This is taken from the paper. These were what they identified. So it may not generalize more broadly, which I guess speaks to what we've already been talking about. Adults with internet access and English or Spanish proficiency. So that's really who completed this. So again, thinking of populations that would be excluded because of that. There was selective participation, and this can, as with everything, if people choose to do something, it can introduce bias, because there are questions around what's got them interested in completing this. I thought this was interesting. Respondents may provide fraudulent responses. I thought I don't even know if I would ever put that in, because it's like, maybe people do. I guess that was interesting to me to note that maybe some people might complete a questionnaire and answer it fraudulently. I'd never even considered that myself, honestly, but there we are. Lack details about the individual context, which I guess is to your point, Niki, in the question you just asked. Although they kind of pick out age, socioeconomic, and gender, rather than maybe kind of healthcare setting in which they receive their care. Name of the study and the survey language could have influenced participant responses with a bias towards more negative response. So they recognize that perhaps the way in which they phrased and put the language in might affect how people answer the questions. And that's maybe where my interest was piqued, and why there was a relatively, you know, high number saying, well, I haven't really had any problems with it, if that's the case. The design of the survey only allowed respondents to answer predetermined questions, although they did have the 3 open-ended questions to allow for some scope to add more information. So I think that's been harsh on themselves there, if I can say that. And this report represents the broadest exam. So this is a real strength. It really does, you know, a huge amount of work and effort, and a huge, you know, sample size or number of people completing it. And it's right that they recognize that it's you know, perhaps the largest study in the world about this so far. So amazing. So their summary, if you like, the TLDR version of this was that 45% of people had heard of the term, but about 1/3 found it problematic. Again, that's that interest. Why is that? 12% had heard it applied to them and stated that this was a negative experience. I mean, that horrifies me as a healthcare practitioner, that anyone would ever use the term in catastrophizing to describe somebody. Anyway. And then clinician education on patient-centered terminology may improve care and reduce the stigma. So if you like, this is the takeaway that the authorship group felt, as they put at the top under the abstract, kind of as a summary version of the paper. Some questions I was left with, but we'd like to open it up to all of you, is, you know, and I think, Andrea, this is where you've given some lovely insight already to Niki, and maybe we'll speak to this about, you know, well, how did the question come up, and what were the motives behind it? Because again, the paper doesn't really give much on the sense of that, and I think that's really interesting and good to hear about. So it's great that you're with us to provide some more depth in that. Who was missing from the team? I guess maybe that's, for me, speaking more to the you know, English and Spanish, and the nature of where it got distributed, and kind of what might have happened if it was distributed in kind of low and middle income countries, as well as high income countries. So that was something of interest. How were patient collaborators involved? There's that one sentence that I highlighted at the beginning, and again, Andrea, you're going to hopefully give more detail on that, because to me, that's really interesting, and it's a shame that there wasn't more about that in for people to read about how it was done. But maybe that's another paper to give more detail on that part, because it sounds like there was a lot of work there that went on behind the scenes, as it were, behind the curtain, or at least not in the paper. Why were there only 2 languages? We've already talked about that. And this idea of the 68% were not so aware, concerned, even with the potential bias in the framing of the survey. What does that tell us? I just thought there was an interesting question there, perhaps to explore or unpick. But they were just some of my thoughts, and share them with Niki before we lit. So I'm curious about your thoughts on this, and where the conversation is going to take us. So I'm going to stop sharing the slides. Are we going to continue recording as we have a discussion?
If Andrea is all right with that, to give us a bit of background, I think this is one of the most important and interesting parts. So Andrea, over to you.
Okay, thank you. So all of this exists in the contextual area of, in the United States, in 2016, the Centers for Disease Control issued new guidance on the prescribing of prescribed opioids for long-term pain that was supposed to be only specific to general practice and primary care providers. However, because in their guidance document, they issued numerical thresholds of a certain number, which was considered prudent on their part, that became a legal framework that our law enforcement, which is the Department of Justice and the Department of Drug Enforcement, or the DEA here, took as law. And I think more than 637 laws were put into place throughout the United States as a result of that CDC guideline. There's a great paper on that by Robert Twillman, and I can share that with you as well. So it completely changed the culture. Physicians became terrified to prescribe pain medicine to patients, and many of them were dropped instantly because physicians were targeted for being high prescribers, and all of this existed in the context of what's called mass tort litigation, where pharmaceutical companies, distributors, pharmacies were all being sued for billions of dollars. I think the settlement now is at $64 billion and climbing. So this is a huge context for why this all happened. As physicians who are generally risk averse, or prescribers, which I completely understand, were no longer sure what was safe to do and what was no longer safe. We saw patients being force tapered off their medications almost overnight. And so for a reason that was given to patients, many were told, you're not actually in pain, you're just catastrophizing. Like, this was offered as a rationale for this kind of epidemic of immediate overnight forced tapering. So I think what you're seeing in some of the responses is the emotional betrayal and outrage that people felt that their care was no longer individualized, but instead it was being driven by political, litigation, monetary, and all kinds of other factors that had nothing to do with them as people in pain. Like, we didn't matter at all anymore. Everything else mattered instead of our own individual needs. And the doctor-patient relationship was devastated by this massive overhaul that we had as a result of this 2016 guidance. So part of what you're hearing there is that a lot of people were told this as kind of a reductive way of letting them know that we're not going to prescribe anymore. We're not going to treat your pain anymore. You should go see a psychologist, or you're the one with the problem. And so I think some of the responses you're getting, even people that hadn't heard of the term, still had an emotional response to it because they did feel as if they were being dismissed, which in many cases they were. And then there were also patients, like inpatient, post-surgical, who were told, you will not receive any pain care because I hear that you had past abuse, let's say, as a child. So that means you're automatically catastrophizing. You have centralized pain syndrome because of past abuse. So I just see you as an addiction risk now, and you will not have your pain treated. So almost overnight here, that whole paradigm shifted. And many patients are very angry. And that's what you'll see on the patients that are on social media in general are usually the angry ones. And so that kind of, especially in the question of why do we even need this term at all? Why don't we just call it pain? A lot of that responsiveness is in response to what happened to a population of over 100 million people in pain in the United States at that time. But how it happened between Dr. Darnell and I was the executive director of a pain advocacy organization called the Alliance for the Treatment of Intractable Pain. And I received a great deal of negative responses for people who just were angry about everything that was happening. And because I was, the director of an advocacy organization, this question was put to me all the time. And for some reason, everybody believed that Dr. Darnell was the originator of the term because she was writing about it and talking about it. And also it's considered a term of art, which is kind of a way of saying, in a certain profession, there's a phrase that's used that has a common meaning to people in that profession. This term was never meant to be discussed with individual patients. It has a specific meaning, a specific application in this profession of pain psychology, but it ended up being used as an excuse to deny patients care. So that anger had a rippling effect and people had a very negative response to it. So because I saw Dr. Darnell getting absolutely thrashed all the time on social media and taking beatings that I've never seen anybody take more abuse than she has taken for something that she had nothing to do with, I reached out to her and I said, tell me what this is all about. What do you believe? What do you think? What is this? All of it. And she was so gracious. She wrote me a 14-page letter back with, I don't even know how many attachments. And she was so grateful that I asked. Her overall feeling was like, if you don't enjoy my work, I accept that, but it would be nice for people to understand it first. And I think she felt misunderstood because she was actually the only person that wanted to not use this term, but somehow she was being portrayed as the perpetuator of it. So I took some time. I read everything she had to share, everything that you so brilliantly presented here today. It was an excellent summary. So thank you so much. You've done a beautiful job with the literature and the paper itself. So as a result of all of that, we decided, she thought, language changes, right? This was developed in 1995, the scale that's being used now. And here we are, 20 years later, and it no longer serves the purpose that it maybe was meant to serve. And so we decided to ask people, how do you feel about, what would you like to have done about it? And as a result of that collaboration, we did bring in, I think, at least 5 to 8 patients. And what patients had to do on this was substantial. Researchers wrote the questions they thought they should ask, but then they asked us, were they well written? And oftentimes they are not. What they think our experience is and what our actual experience, like questions like rate your average pain, seem like a great question to a researcher, but are very difficult for us to answer, right? Like compared to when? Like last week, last year, when I was 13, they don't have, so we help them reframe questions in a meaningful way to us. We also help distribute the survey and, share it with all of our own networks. Then we helped edit the paper itself. When it was, being drafted, there were multiple revisions and we all shared the document and we all edited together to craft the language and make sure it communicated what we were hoping to communicate. And then we also, shared it and promoted it as well as we could afterwards. So I would say we were involved in every stage of the study from beginning to end. And we were not compensated for that work. It was all voluntary contributions to hopefully advancing this entire topic and moving it forward.
It's such a shame, Andrea, that isn't captured in because that's so powerful what you shared and kind of that amount of. and I know it's always difficult in papers, but just to have a sentence, you know, patient collaborators participate in the design of this, it really doesn't give the breadth of what you shared, and feels like you should do a video of what you've just showed us and kind of share that along with the paper would be wonderful, I think.
Thank you. I did write it out. I did write it out for Niki, so she can share that with your group if that would be helpful. I'm so grateful that you asked, because I feel like the paper is one of the best written papers on this topic. I hope that it gets more traction. I have seen this question now being asked in other professional literature, like it has spurred this conversation forward. And I think we're all in agreement. We don't just want to change the term, but continue the stigma of using it. We'd actually like to make it have a meaningful difference in, you know, relieve the intrusiveness and pain in people's lives. Like that's our actual goal. Nobody wants to carry stigma forward. So we're not just trying to like slap a new term and say it's all better. We'd like to transform the reductive and stigmatizing nature of it to mean instead, I think it's clear that the actual scale has been replicated enough times that it's been validated, right? Multiple times. The data is pretty clear that if you score this highly, there's a good chance that if you worked with a quality pain psychologist that you could bring down some area. Matter of fact, I even found one of my own. You know, I'm 18 years into my intractable pain experience, but even I realized that I had been projecting like my pain had started here and like gotten worse like over time. So I have always thought that it's going to continue on that trajectory until I die. But I realized, what if, you know, today is the worst day it'll ever be and it will never get any worse than this? How would that change the way I perceive the rest of my life? So even in doing this paper, I kind of changed my own thinking about pain, which kind of gave me some new hope. So I do think it's a helpful construct if it's used helpfully, but when it's used to deny care or dismiss care or to, you know, be insulting or dismissive of people in pain, that's where it's harmful. And that's really what we'd like to affect the change in. But it starts with language, right?
I mean, thank you so much. That is just so insightful and so helpful. And if you don't mind, I think I am going to stop recording now because we have a limited amount of time for discussions.